Alright, guys, so we're going to talk about plastic surgery. I looked through this chapter and there was a whole bunch of little details about different things, and I just kind of thought that I would base this podcast on the reconstructive ladder, kind of the thought process you should go through with any wound you have, which is kind of what all plastic surgery is based off of. So we'll just start there. So, reconstructive techniques. So, the reconstructive ladder that you'll hear about, you'll see different pictures that have some kind of variations in what's on each ladder, but kind of the basis is the same. So it helps you move from simple to complex techniques of wound closure or repair. You have to consider the characteristics of the wound, so the size or tension on the wound, any exposed structures, the location or functionality of the area. And goals of this are for form, function, and safety. So you want to choose the least aggressive method initially and then rise up the ladder as necessary without burning any bridges. So the first kind of step or step on the ladder, I guess, that you can use are just dressings, which help wounds close by secondary closure. So these are applied to the wound to promote healing and prevent further harm. And again, allow the wound to heal by secondary intention. So the aim is to maintain a moist environment without excess exudate. And there are multiple examples of these that I'm not going to go through, but I think most commonly we kind of see wet to dry dressings or wound vacs. So next we have primary or delayed primary closure. We all know about primary closure. You're just, closing the wound with sutures. If patients have a traumatic or a dirty wound, they could require debridement and then delayed primary closure. And then there's just the basic surgical principles. So you want a slight eversion of the skin edges, minimal tension, gentle handling of the tissues, use the right suture material, make sure it's not too tight, excise any dog ears, and eliminate dead space with drains or deep sutures. Next is skin grafting. So this is a block of tissue transferred without blood supply. It's classified according to the tissue of origin. You can see those listed there. You either use a split thickness or full thickness skin graft, and graft survival depends on graft quality and the quality of the wound bed that you're applying to the graft to. So stages of graft take. This is everyone's kind of favorite skin grafting question. So over the first 8 hours, there's some adherence of the graft to the bed. And this can easily be disrupted by shear forces. So you'll see they try to, immobilize areas that'll have a lot of movement, or they have kind of a good pressure dressing on there to keep the skin graft adhered or pressed down to the wound bed. So for the first 2 days, the graft receives its blood supply by imbibition, which is kind of osmosis or diffusion of nutrients or blood supply through the graft, and that is how the graft stays alive during those days. From days 2 to 5 is when inosculation starts, which is technically kind of new blood vessels growing into and almost like anastomosing to the blood vessels that were already present in the wound, which this is kind of debated as if this actually happens or if there's just neovascularization or new blood vessels are made. But it's a combination of inosculation and neovascularization, and then remodeling following that. So there's your split thickness skin graft, so it's your epidermis and part of the dermis, and as you can see here in this picture, you can either do a thin, intermediate, or thick-sized split thickness graft. Advantages are this can be meshed to increase the coverage. The donor site will heal kind of spontaneously. You don't need to do anything else to it, and then you can actually reharvest from that same area once it has healed. So split thickness grafts do have increased secondary contracture kind of as they're healing. And disadvantages are they lack volume, or they're not very thick, there's not much there, and they can develop patchy pigmentation. Full thickness skin grafts are the entire dermis and epidermis. They're kind of limited in size because you leave a defect with no healing potential, so that's going to have to be closed or have a split thickness graft applied to it. And you want to choose a donor site that has good color and texture match. So they usually say kind of if you're grafting like the face, you want to use an area that's close to there, if possible, to obtain your skin from. Full thickness grafts, the advantages are they kind of retain their volume and pigmentation. They have less contraction, and they keep the adnexal structures, or like the hair follicles and whatnot. So disadvantages, there's more donor site morbidity, so it limits the size that you can take. They don't take as well as a split thickness graft, mostly because they are thicker, and so for that imbibition, the diffusion that it has to go through, that's much thicker, so they can't have more difficulty with that. And then, it also can be a disadvantage to have the hair or the adnexal structures retained. If you're trying to graft somewhere that doesn't naturally have hair and they're going to have hair growing there, that could be weird. Most common cause of skin graft failure is a hematoma under the graft. Other complications are shearing movements, infections, seromas, poor wound beds, poor graft characteristics. That's why they often do this bolster or tie over dressing for 4 to 5 days, which is where they kind of put a big bulky dressing in the middle and then, tie sutures at the corners or edges of the graft and then tie those over top of the dressing to keep it pressed down on that skin graft. All right, tissue expansion. So obviously this is not used for kind of acute wounds. This is if you are planning something, something that you need to resect down the road, that you're going to have difficulty closing. This is something you can consider. So they increase the surface area of the locally available skin. So you place this implant or expander implant into a subcutaneous pocket, and then following that, you serially inject it with saline over weeks to months. And then the expander is removed once you have your tissue expansion and the skin is advanced. So what we're most used to seeing this with is with breast reconstruction. Lots of skin is removed when patients have a mastectomy. So these tissue expanders are placed and then expanded so that there's room for an implant to be placed, and then they are taken back to the operating room. The expander is removed and an implant is placed at that time. So advantages of this, you're reconstructing with tissue that's similar in color and texture to whatever the area. It allows for reconstruction with sensate skin, with appendages, limited donor site morbidity. Disadvantages are this is painful, prolonged, multiple procedures and clinic visits. And this has no role in acute injury. So the next step up the ladder would be a flap, which is considered a unit of tissue which maintains its own blood vessels while being transferred from a donor site to a recipient site. So there are 3 kind of broad types. There's random pattern, pedicled, and free. There are numerous classification systems, but kind of a simplified version is to look at the 3 C's. Circulation, or the blood supply. You can have named or unnamed, or a random vessel blood supply. The continuity, or the donor site, is it local or distant, pedicled or free, and the composition or the type of tissue. So composition, they can be a single or multiple tissue types. You can have cutaneous, fascia and skin, fascia, muscle and skin, bone. Next you look at the circulation. So random pattern flaps have no directional blood flow or no named vessel. They rely on this dermal subdermal plexus. So usually this is when you're doing kind of small little local rotational flaps. These are things to keep in mind. And they're limited in their length to width ratio, so it's 1 to 1. So these usually have to be pretty small. Axial pattern flaps are named depending on, the course of a vessel. And then this, I don't think this is something you at this level really need to memorize, but for musculocutaneous flaps that have obviously muscle and skin, there is this typing system that's been described. So type 1, they have a single pedicle blood supply. Type 2, there's one dominant pedicle with additional minor pedicles. Type 3, they have a dual dominant pedicle. Type 4 are segmental pedicles. And type 5 is a dominant pedicle with secondary segmental pedicles. So, like type 5, this kind of using this thought process or knowing kind of what type of flap it is can help you. It's like the latissimus dorsi flap. Obviously, we hear about it used with breast, which is based off of its dominant pedicle, the thoracodorsal artery. However, it does have all these segmental pedicles, or, they're kind of paraspinal pedicles, that you can use that as a flap that direction to kind of also cover, based on those pedicles, to cover, spinal defects or something like that. Then you can have local, regional, or distant flaps, and the distant flaps can be either pedicled or free. So pedicled, they're based on a named vessel, and the flap remains attached to this pedicled vessel and is not detached from the donor side. Free flaps are when the tissue's moved from one area of the body to another, and they're disconnected and then reanastomosed. They're based on these known axial flaps, so you use the same kind of blood supply that you know of, but it's just kind of to be able to move them to another side on the body. It involves tissue ischemia, hypoxia, and reperfusion. Kind of the riskiest reconstructive option is highest up on the ladder, kind of your last choice. Advantages of free flaps. There are single stage procedure. You have a different choice of your donor tissues. A large volume of tissue can be transferred. Can help optimize the vascularity. So, as we'll talk here in a minute about, tram flaps are based off of, if they're pedicled, they're based off of the superior epigastric artery. However, they found that the inferior epigastric artery is the dominant blood supply to those areas. So if you make it a free flap, you can base it off of the inferior epigastric artery, which kind of helps improve its blood supply. You can choose the high donor defects, especially in the breast. So patients who get tram flaps or deeps, as we'll talk about here in a minute, they actually end up getting like a tummy tuck with that, because that's how they kind of close the donor site. Disadvantages are it's a long and specialized surgery. They're using microscopes for a lot of these to do these anastomoses, using 9/0 sutures. It takes, a long time. It's very delicate dissection and operation. It's high risk, as patients can lose their flap. You don't really know the quality of the recipient vessels very well until you get in there, and they could be poor. And then also donor site morbidity, which varies according to the flap. You can have scar, hernia, loss of function, etc. So then I'm just going to go through a few examples of these. So a pedicled tram flap, or a transverse rectus abdominis musculocutaneous flap, is based off of the superior epigastric artery, as I mentioned. You dissect down and you are taking the fascia and the muscle associated with the rectus, and then leaving it attached to its pedicle with the superior epigastric artery, and then rotating it up for, breast reconstruction. And then, as you can see, they get closed and they kind of get a tummy tuck there at the end for the repair. They did find some kind of complications with this. As you're taking the muscle, you can get bulging, herniation, and whatnot on that side, which can lead to complications down the road, and some loss of function, from not having the rectus on that side. And then a free tram flap, as I mentioned, the dominant blood supply is the inferior epigastric. So this is where they kind of take that based on the inferior epigastric pedicle, and then they move it up, and they often anastomose to the internal mammary artery. So they actually go down and kind of resect part of the third or fourth rib, and then anastomose to the internal mammary artery and vein there, which is actually pretty cool. The deep or deep inferior epigastric perforator flap. This was kind of developed as, people usually have a lot of subcutaneous fat down there. They don't necessarily need that muscle bulk as part of the flap. So these kind of identify these perforators. You do make an incision in the fascia and cut kind of these perforators out, and then you're able to follow them down to the inferior epigastric artery, but you are able to leave the rectus in place. And so you're just taking the skin and subcutaneous tissue up and anastomosing to the internal mammary artery. There's also multiple others that I just am showing some examples. So there's the anterior lateral thigh flap, which is based off of the lateral femoral circumflex artery. There's the radial forearm flap, which is based off of the radial artery. It's a lot thinner, as you know, obviously you don't have as much fat there, so I've seen them do this flap to cover kind of like a, anterior ankle defect, just because there wasn't as much tissue there. That you can use this to reconstruct the tongue. And then also, as you can see in that picture on the left, they have reconstructed penis with this radial forearm flap. So it can be used for multiple different things. And the latissimus dorsi flap, so this is based off the thoracodorsal. It's often a pedicled flap. They make that incision in the back, kind of identify your pedicle, resect out the muscle, and then move this up. And then any extra skin that you have, you can kind of deepithelialize and then just use what skin you need to close your defect. But these, you kind of end up with a large scar on the back, but they are used for breast reconstruction. So a summary of the reconstructive ladder. It's the basis of plastic surgery. It's a variety of reconstructive options. Sometimes there's no wrong or right choice, and you just kind of need to have a patient discussion on a case-by-case basis. Wise to start on the bottom rung of the ladder, kind of work your way up, and don't burn any bridges.